For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 15 of Surfing the NASH Tsunami, our review of the second annual Liver Connect meeting sponsored by Chronic Liver Disease Foundation, starts now.
This week on Surfing the NASH Tsunami.
I thought the decision to make the NASH Connect session so much about health disparities was a really interesting choice.
NAFLD was initially thought to be the disease of Western countries, the United States, and that's absolutely not true anymore. It's a global disease, and it's impacting probably other regions of the world even more rapidly than us. The highest prevalence and also the highest burden of disease in the Middle East and Asia. Really a poster child. NAFLD is a poster child, sort of health disparities that impact, that causes a disease.
That session on disparities in different regions of the world and globalizing our knowledge about fatty liver disease and NASH opens the possibility to do what we need to do, which is to try to tackle this at the global level and utilize everybody's resources and the incredible networks that we have to try to tackle this condition.
Around about 22% of the population, indigenous health, actually in the cities and have poor access to quality food. But when you go rural, that's up to 43% of that population. So if we're only addressing populations in city centres and in local facilities, we lose the patients who are actually most affected by food insecurity because they can't get it, you can't travel with it. It's always funny how a fast food outlet can always get the food to those areas way better than anybody else.
If you want to pick one statement that can get people to sit up, it's American diets today are damaging the livers of 1 out of every 5 kids in adolescence. That's a pretty intense number. Sometimes you really have to just cut to the heart of what matters.
There are a lot of foundations that they help medical research, and a lot of them are focused on cancer, which is a very, very important topic. But guess what? Obesity leads to cancer, and if it's not one of the most common associated factors or cause, fatty liver is associated with cancer. So I'm gonna call people, hopefully to help us. The Gates Foundation, Miss Melinda French Gates and Dr. Priscilla Chen, that they support medical research to support us.
In our offices in Arizona, we offer FibroScan for anyone who's interested, and we do about 1,000 FibroScans each month. And as you said, 80% will have low liver stiffness, and we can reassure. So only 20% will end up coming. I know we have a lot of work. I know we're not there, but this is where I would like to be in the future, with point-of-care ultrasound that can measure liver stiffness, and this is how you get more accurate results than AST, ALT, or FIB4.
Last weekend, over 400 NASH and NAFLD stakeholders came to Scottsdale, Arizona, for the second annual Liver Connect conference from the Chronic Liver Disease Foundation. This week, we have organized a panel of attendees to help process the conference's high points, key takeaways, and next steps. Join hepatology researcher and key opinion leader, Dr. Stephen Harrison, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and today's guests, key opinion leader and CLDF Vice President Marcelo Kugel-Moss, and hepatology researchers and key opinion leaders Drs. Mazen Nuruddin and Naeem Al-Khouri, as they review NASH Connect and Liver Connect today on Surfing the NASH Tsunami.
Today's episode of Surfing the NASH Tsunami is sponsored by Madrigal Pharmaceuticals, a clinical-stage biopharmaceutical company pursuing novel therapeutics for NASH. Madrigal's lead candidate, resmetirom, is a once-daily, oral, thyroid hormone receptor beta selective agonist that is designed to target key underlying causes of NASH in the liver. Resmetirom is currently being evaluated in 2 phase 3 clinical studies, MAESTRO-NASH and MAESTRO-NAFLD-1, designed to demonstrate multiple benefits in patients with NASH. For more information, visit www.madrigalpharma.com.
Для всіх, хто цікавиться мережею NASH або загалом жировою хворобою печінки, ловіть хвилю.
My thanks again to Anna Tokar for translating our opening statement into Ukrainian and saying it so we can offer special welcome to Ukrainian colleagues and friends across the globe. For those of you in the Northern Hemisphere, happy end of winter. It's expected to hit 70 degrees Fahrenheit here in Pennsylvania today, or I guess 21 degrees Celsius if you count in Celsius. The tree leaves and the first flowers are budding. The days are getting longer. It becomes easier to be optimistic, or at least to enjoy the day when this is the weather. Today's episode, which reviews last weekend's second annual Liver Connect and the accompanying half-day NASH Connect event, has two sections. In the first, I conduct a 20-minute interview with Chronic Liver Disease Foundation President Dr. Zobair Younossi, while the second is a more typical panel with CLDF Vice President Marcelo Gugelmas, Naeem Al-Khoury, Mazen Noureddin, and Louise Campbell. Collectively, these two discussions present a clear picture not only of what happened in the NASH-related sections of the CLDF-sponsored event, but also the objectives the CLDF board had for this meeting in the first place. Listen and enjoy, and may I recommend you already start planning your Q1 2023 schedule to make time for both NASH Tag and Liver Connect. And with that, let's listen to my interview with Zobair Younossi from the top.
To start our episode, a conversation with Chronic Liver Disease Foundation President Zobair Younossi and Roger Green.
We are fortunate right now to be joined by Zobair Younossi, President of the Chronic Liver Disease Foundation, and really one of the most preeminent hepatologists, or anybody really working in fatty liver space in the world. Zobair, thanks so much for joining this morning, and congratulations on a fantastic conference last weekend.
Thanks very much, Roger. Appreciate it.
Please do me a favor, if you can. Just take a couple of minutes before we get started. Tell our listeners, most of them probably know or know of you, but some of whom won't, a little bit about yourself and your history and how you got to where you are right now and what you're doing. And then end that with one fact that we wouldn't know about you if you didn't happen to mention it today.
Okay. And I started actually my career after finishing a fellowship at the Scripps Clinic Research Foundation in California to the Cleveland Clinic as a hepatologist and senior researcher. During my fellowship at Scripps Clinic, I also did a Master of Public Health, and specifically focusing on sort of public health issues as well as outcomes research. I was at the Cleveland Clinic for about 5 years, and there I really started my career in two areas of hepatology: outcomes research, specifically around patient-reported outcomes and quality of life, and then really started the research on non-alcoholic fatty liver disease. That term was coined when I was at the Cleveland Clinic in 1997 and really led to the paper that ultimately sort of started the field of non-alcoholic fatty liver disease. And when I moved to Inova Health System, and currently I'm the president of the medicine service line here and chairman of medicine, we continued that theme of non-alcoholic fatty liver disease and aspects that are related to clinical research, clinical trial, but most importantly, outcomes research in non-alcoholic fatty liver disease. And that's where I am. We publish about 20 or 30 articles a year and are active in this field for the past 20 years. We've published over 600 now. So, and a lot of it is related to fatty liver disease, I would say, the vast majority.
Okay, so what's the one thing about your audience wouldn't know if you didn't tell them?
What they may not know is that I'm a Scotch drinker, and it is one thing that I have that as a hepatologist, you're supposed to limit your alcohol consumption, which I do, but I do enjoy a great single malt Scotch.
Are you a collector?
I am, about maybe 20 or 30 different kinds.
What's the best bottle you have?
Well, I have a good Yamazaki, an old one, but my daily sort of consumption is a brand called Oban.
I know them both. And I'm not particularly a Scotch drinker, but they're both great brands. And we've had 65, 70 guests on this podcast, and you're the first person who ever cited his Scotch collection. One more way in which you are unique, my friend. So just to start, this was the second Liver Connect and second NASH Connect, I guess. How did you folks come up with the idea in 2020 or 2021 or whenever that this was a program that CLDF wanted to start, and then specifically why NASH is a almost separate cutout within it, both?
Well, I think the most important issue was that we wanted to have a program that could complement a lot of other scientific programs that we go to that specifically are going to connect the practice of hepatology, gastroenterology with what we see in the scientific sort of meetings. And it's really very practical for colleagues, not only in just gastroenterology and hepatology, but our advanced providers, practitioners, our endocrinology colleagues, especially when it involves non-alcoholic fatty liver disease. So this came out of that sort of an idea to make Chronic Liver Disease Foundation be this vehicle to be this connection, not only between the scientific meetings and providers, but also connect the industry to providers, and really at this point, even the public health issues to providers, so people have a comprehensive comprehensive understanding of the entire liver disease, but specifically some areas that are much more important in terms of needs for awareness, which is non-alcoholic fatty liver disease.
In addition to non-alcoholic fatty liver disease, are there other areas that you think there are particular education gaps that need to be met?
Well, certainly, I think alcoholic liver disease, which is the number one cause of liver transplantation in the United States, non-alcoholic fatty liver disease is second indication for liver transplantation. These rates are actually going up, and I think we need to better understanding of alcoholic liver disease, and also hopefully better treatment of alcoholic liver disease. Some of the cholestatic liver diseases, primary sclerosing cholangitis being one, there is really no treatment that's approved for primary sclerosing cholangitis that could help these patients. Viral hepatitis B is a major challenge worldwide, and of course now hepatitis D, Delta virus. These are the areas that we need to really focus on. So there are plenty of areas that there is an opportunity to improve knowledge.
I think that's fantastic. I was impressed as a non-scientist. I mean, people who listen to this podcast know my last natural science course was high school biology. I'm self-taught beyond that. I thought that throughout the meeting, the presentations were exceptionally accessible. They were scientific, and yet you didn't have to know all the content to be able to figure out what mattered and what you were talking about. I think that was really well done.
I think the idea was to, number one, make it really accessible, and not only in terms of content, but also accessing the meeting. So this was in 2021 when we had the first meeting. It was the first live meeting for hepatology because it was around April of 2021. But we decided to have it done outdoors because of COVID sort of peak, and then really provide the opportunity to have live meeting available also virtually. Now we carried that philosophy again this year, where we had the meeting live with 400 individuals who participated, and then it was available virtually. There was, I think the last count was somewhere between 650 to 700 other individuals participate live during the entire meeting. So this capacity to use new technology to reach more colleagues across the world at some point is going to give us sort of the opportunity to get the word out to even a larger audience.
That's great. I was going to ask about the geographic reach, because one of the things that surprised me as this podcast started to get a little bit of traction was how many countries we were getting downloaded in every week. A typical week here is about 25. It goes up as high as 30, and Buzzsprout tells me we've had downloads from 95 different countries since we went live in July of 20. Do you have any sense of how many countries were tuning in remotely?
Now, I don't have the numbers for this meeting, but Chronic Liver Disease Foundation is also collaborating with a global liver council that we have and global NASH council that we have. That's about 40 different countries that are members of that. And as we get this more solidified in the future, all members of these different councils that we have will be invited, not only themselves to participate, but also to bring in their colleagues' countries. So that's where we're going with this meeting.
That's great. The world can't possibly get enough education on these issues, so that's a fantastic thing. Going to the agenda for 2022, the second Liver Connect, I thought the decision to make the NASH Connect session so much about health disparities was a really interesting choice, and I'm wondering what it was that motivated you to make that the focus of that particular session and what you're trying to achieve.
Well, I think there were a couple of reasons. One is that NAFLD was initially thought to be the disease of sort of the Western countries, the United States, and that's absolutely not true anymore. It's a global disease, and it's impacting probably other regions of the world even more rapidly than us. I mean, the highest prevalence and also the highest burden of disease in the Middle East and Asia. Really a poster child. NAFLD is a poster child, sort of health disparities that impact, that causes a disease. The fact that the prevalence is driven by nutrition and exercise, and that drives the metabolic conditions of visceral obesity and type 2 diabetes. These all have major health disparities factors that impact them. So that's not only true just for the United States. As you know, the prevalence of NAFLD and NASH and even progressive liver disease is highest in the United States within Hispanic Americans. In the world, as I mentioned, in the Middle East and Asia, North Africa. So again, we need to sort of take a broader perspective about this disease, that this disease is driven by factors that are impacted from a risk standpoint by some of the socioeconomic issues that we don't always think about as physicians. The second thing is that we're developing new non-invasive tests to risk stratify patients with non-alcoholic fatty liver disease. The highest risk has to be, and sometimes we forget the fact that some of these NITs or these tests may not perform the same way in one population versus another population. So we have to be very careful that as we develop these tests, that we validate these tests across the world. This is not a hepatitis C RNA test that probably performs exactly the same no matter where you are, as long as you use the same platform. A lot of these tests actually have to use the environment of the patient, and that environment changes when you're dealing with different ethnic and geographical and regional issues. And the last is that we are developing treatment. And again, because we have disparities in terms of clinical trial enrollment, because the clinical trial of drugs are focused on getting approval from the EMA and FDA, they basically enroll the type of patients that would make it most likely for the drug to be approved. But forgetting the fact that probably larger number of patients with NASH would be outside the FDA and EMA sort of approach. So just to make sure that we then take the efficacy of these drugs and make sure that it's effective, not only in the Western population, but also in the rest of the world. And finally, which is I think is probably more important, is that the awareness about this disease. The awareness is dismal in the United States or even Europe, especially for the frontline providers like primary care physicians or endocrinologists. If you take this low awareness about NAFLD to the rest of the world, it's even worse. So you can't really make a dent in this disease until you actually raise awareness about the disease among the stakeholders. And there is no more important stakeholder about this disease than not only the providers, but also policymakers. And when we looked at the policies, national policies that even mention non-alcoholic fatty liver disease across the world, you'll see that there is almost none that has sort of a national policy. And this is going to be a major challenge. If we don't address that, we're not going to really make a huge difference in this disease in the future.
I think you and I are both going to be in Barcelona in May for the first Innovations Conference. We had Jeff Lazarus telling the story of nothing getting higher than 50 or whatever it was. And one of his European friends saying, well, that might be a passing grade. And him saying, not in the States it wouldn't be. That there isn't anywhere in the world that has a program comprehensive and focuses appropriately. Are there places that you look at and say, well, they've got this piece right, even if they don't have the rest of it? Have we gotten to the point yet where there are places that are doing well enough with elements of public policy around NAFLD that we can say that's what other people should be looking to?
I think the United Kingdom has some good programs that could be expanded and modeled. I think there are some good programs that are getting started in the United States. I think there are patients' entities here that can help with at least raising awareness at that level. But I think most of the world is really starting from level of 0 or maybe 1. So I think it has to be a way that we're raising the awareness about the importance of this disease to get at the policy levels perspective. On the other hand, then we should leave sort of some regional differences because the challenges are different in a closed system of healthcare than an open system like the United States. So that sort of country-specific and region-specific characteristic of the policy should remain our regional sort of challenges. Raising this to the WHO to even consider non-alcoholic fatty liver disease as an important non-communicable disease would be very important.
Yeah, I know that's something that Jeff and Jorn Schattenberg have talked about when they've come on this podcast to talk about the work that they're doing. The idea that WHO has not historically even mentioned NAFLD in any of their liver directives or policies is, I agree, I think it's a striking thing. The folks put on a really excellent group of presentations about health disparities. I think it was interesting that it's not a subject they talk about, so folks really had to dig down and go back and do the basic research, which made for, I think, some fascinating presentations. I'm wondering what you hope will have come out of the Thursday session. You mentioned a couple of areas where you'd like to influence awareness. How do you see that session translating into, say, creating awareness among public policymakers or among treating physicians in the different markets?
I think it's going to be important to remember that this disease is so complex from not only risk factor standpoint, the social and socioeconomic food insecurity aspect of what drives NAFLD, that when we're looking at an NIT performance or a target for treatment, that those are really the tip of the iceberg. I think over the next few years, as we develop those NITs, we need to really focus on how to raise awareness through education about the importance of disease and clarify which patients would be at highest risk and how to stratify those patients with these NITs. Of course, the other important thing that I think will hopefully will come out of this will be to develop care pathways for patients with non-alcoholic fatty liver disease that involves not just a hepatologist, that involves more than a hepatologist, that you connect, that you utilize the technology of, say, virtual care that we are now used to because of COVID, to now connect a nutrition and dietitian who was very hard to get 5 years ago as a part of your team, or an exercise specialist or an endocrinologist, to now connect and really develop these care pathways, because at the end of the day, it'll be through care pathways that then we can deliver the optimal care and not only, a treatment, but even management of these patients. I'm hoping that by expanding this view in some ways to include others in this larger tent, that would include not just hepatologists, but other providers, but also then understand that in order to make a dent, we need to sort of raise awareness and focus on which patients from this really universe of non-alcoholic fatty liver disease would be at highest risk and should be targeted.
That's interesting. So one thing I wonder about is, I think Dr. Harrison mentioned this, the idea that we've now got multiple people putting out multiple pathways. He thought that would be confusing. He just said we should all have one way of doing this. There's another school of thought that says that if everybody becomes aware on their own terms, eventually it'll all converge. Do you have a preference for whether organizations put out their own, or whether we try to get everybody to adhere relatively quickly to one common guideline or way of doing things?
I think at some point, everything that folks are going to do has to be evidence-based. And if you really are looking at evidence seriously and accurately, you'll come to the same conclusion. There may be some small tweaks that here and there based on, for example, for risk stratification, what will be your second test, not what your first test would be, but what your second test would be. And that's okay, because that will give options to folks to have more than one options. But I suspect in terms of risk stratification, we will have probably more of a unity in terms of these guidelines coming together. It will be very hard to, if you're developing evidence-based guidelines or algorithms, that will be very different from another one, because otherwise, somebody's not following evidence-based sort of assessment. In terms of treatment, the first treatment is, I think everyone is in agreement with the first treatment, which is basically lifestyle modification. I don't think anybody would argue against that. Now, in terms of, medication, we just have to see what data is out there. And if we're lucky enough that in 10 years we have 10 different medications, then you have to basically pick your patients based on personalized medicine sort of approach and find what target should be the best target for that specific patient. So at some point, I think it's going to all come into a unity and cohesiveness in the future. I'm optimistic about that.
I am too. And I guess my view of how the world works is that even if people engage things in 7 different ways right now, which is that evidence will ultimately drive the discussion, and evidence may leave 2 options or 3 options, but it isn't going to leave 8 options. I'm more interested in how we get specialties to align on their role in things, so that you don't have, if you think about baseball, the worst thing that happens in a baseball outfield, I should probably use a more global sports metaphor, please forgive, is that the right fielder, the center fielder look at each other, no one goes for the ball, and it drops on the ground when either one of them could have caught it. My only hope is that as all this evolves, that no patient will fall through the net. Every patient will get caught somewhere.
I think that's very important, but I've been sort of through this journey over the past 25 years, is that initially we had to convince our hepatology colleagues that this is an important disease. Of course, we're 100% there now. And then we had to actually take our gastroenterology colleagues to convince them that it's an important disease. And maybe we're about 80% there. We started actually working with our colleagues in endocrinology, and with the ACE guideline that Ken Kuzi and Scott Isaacs, myself and Mary Ranella and others are actually working on, hopefully will come out, there's going to be more onboarding of endocrinologists. The group that we need to really start the dialogue with even more seriously is our primary care physicians, and how to engage them that this is an important disease, that they see a lot of these patients in their daily practices. And it's important to remember that non-alcoholic fatty liver disease is a complication of diabetes. So if you have no problem sending your diabetic patient to get an eye exam for retinopathy, or check a creatinine test to check their kidney function, why can't you actually do a simple test to look to see if they have significant liver disease or not? And I think that sort of a philosophy and approach is about to also come to our primary care physicians, hopefully over the next few years.
Yeah, I think that's excellent. And I know that the initiative that the AGA started through Dr. Conwall brought in primary care even in the early papers, the 2 papers that were drafted last year. So let's hope that goes forward. I think your point's dead on there. Okay, so shifting from Thursday to Saturday, I thought the format of the Saturday morning NASH sessions, basically a roundtable with a couple of short presentations, was different. How did you come to decide to do it that way, and what were you hoping to accomplish?
I think my own sort of feeling is that when we go to all these different meetings and we hear superb experts give a lecture, lectures have value, but limited value. If you have 10 people in the panel and you get everyone's insight and input about something, I think that's a lot more valuable, and it engages the audience a lot more about the specific issues that they're interested in. So that was the whole idea, to actually have short presentations to set this stage and then have the large panel to then really address specific issues and questions that were raised by the audience, both from not only from audience that we had in the room, but also through the internet with our virtual audience as well.
Did that session go as you hoped? Were there things about it that particularly you liked, or you might do a little differently next year?
I'm biased, obviously, but I loved it. I thought it was great. I think having questions answered by others in the panel, sometimes, not completely agreeing with each other, was exactly the way we wanted to see this. So I think that format works very well.
So I'm less biased, and I completely agree with you. In fact, my favorite moments were moments where we went from somebody providing a theoretical answer to someone else going on and saying, well, here's what I would do with the patient, right? And that I thought that came together really neatly. Is there anything that you would like people who walked away from that session to think about or do differently as a result of having heard it? Or were you basically providing baseline and background education for folks who are already motivated?
The key to this, from my perspective, is to point at one thing that is absolutely, I think, is the heart of our challenge moving forward, and it's about awareness of the disease at all levels. If I can, ask each one of the members of the audience, as well as faculty, to be the ambassadors out there when they hear something like this session for fatty liver disease, to take the message out and be ambassadors for folks to understand that this is an important disease. It's not going to be very simple to resolve, but we are going to be at it, and we need more folks to understand that we need a larger village to make a dent in this important liver disease.
Amen to that. Anything that you can envision yet for the third Liver Connect that will strengthen or broaden this fantastic session you put together last weekend?
I think it'll be more of the same, probably a larger audience, virtually as well as in person. We do actually obtain surveys of our members. Remember, CLDF has a large number of members across the United States, actually even across the world. So we're hoping to get more insight from them about what are some of the topics amongst these hot topics that we think are important that they want to hear about, and really design this educational sort of program for 2023 based on the input that we get.
What input that you got in particular helped shape what you did this year?
The fact that there was a lot of practical information that people received was very important to our provider audience. We also had good interaction from the industry audience who was there, that this field sometimes can feel like frustrating in terms of drug treatment, but there is so much enthusiasm and so much opportunities here to really connect with the practitioners at the front line to understand their issues and address that, how a new test is going to come to the market and how the payers are going to address this. We had a payer session actually, and on Thursday also, that was a parallel thing. So hearing from actual practitioners for GI and hepatology was probably a very important thing that I heard universally from our audience, in addition to the scientific content.
So what question haven't I asked you yet about Liver Connect, or what message do you want to deliver about the meeting or the work of CLDF that the floor is yours? What would you like to share?
Well, with CLDF is probably in my view, and again, I'm biased, is that it provides the most comprehensive educational activities to all stakeholders. So we've started, of course, with physicians, with hepatologists, gastroenterologists, and now we're expanding to the APPs, not only within just GI, but endocrinology and even our fellows. It's just to understand that stakeholders are large. So payers, industry, and even policymakers are going to be hopefully a part of the future of what CLDF can reach out to and make it a part of this larger tent that then ultimately can make a difference in changing trajectory of all liver diseases, and specifically non-alcoholic fatty liver disease.
It's a great goal. Let's see what we all can do collectively to get there. And certainly CLDF has been playing and will continue to play a major role in all that.
And now, our main conversation with CLDF Vice President Marcelo Kugel-Moss, Mazen Nuruddin, Naeem Alkhouri, Louise Campbell, and Roger Green.
I'm back from a delightful weekend in Scottsdale, Arizona, where CLDF had their second annual Liver Connect conference. We did not preview this conference, but we are covering it. We are happy to follow up on it now because a lot of interesting things happened at the conference. We have with us today three folks who spoke at the conference, two of whom are no surprise to you, Mazen, or not strangers to you, Mazen Nuruddin and Naeem Al-Khoury. And then Marcella, welcome to Surfing NASH. Great to have you here with us.
Thank you. It's a pleasure to be here.
Do me and our listeners a favor. Take a couple of minutes and tell them a little bit about yourself and kind of what you're doing these days and how you got to this place. And then in the end, please share with us one fact that people wouldn't know about you if you didn't tell them. You got some stiff competition. You've got Naeem's music career, Mazen's sports career, and other things you can't even imagine. But go ahead. Floor's all yours.
I'm a practicing gastroenterologist and hepatologist in Denver, Colorado, in the south side of town. I'm with a group called South Denver Gastroenterology, where I focus my practice on liver disease and clinical research. We are 24 doctors and 8 advanced practice providers. We have several offices and ambulatory surgery centers. My career has been dedicated to liver disease and its advancement in multiple ways. The way that I get here is through my work with the Chronic Liver Disease Foundation. And what defines me, I think, is that I use work to have fun and hang out with people like Mazen and Naeem at meetings and get them to stimulate my brain. And along the way, we all try to improve medical care for our patients. You wanted to hear something quirky about me. I'm a Trekkie. I like Star Trek. I think that the test that we need is the handheld tricorder, and all our problems will be solved. So we just need to get Dr. Crusher to come and teach us how to do all this.
That's great. So basically what I'd like to do today in the time that we have, and I know we're a little late getting started, is to talk about two things. First of all, the Health Disparities panel on Thursday. Now, Mazen and Naeem were part of that panel. Marcella wasn't. And a little bit about how you thought that went. I thought I'd never seen a presentation like that from a senior KOL group in a meeting before. So I was fascinated. Naeem, what item did you speak about on the panel on Thursday?
I spoke about disparities in NAFLD care in South America and Mexico. And the first session was to talk about different parts of the world and what are the key unmet needs and areas of disparity. So when I discussed, South America and Mexico, I started, first of all, by discussing data on the prevalence of NAFLD. And we realized that in South America, they have one of the highest rates. In one systematic review, it was at 31%. But we also realized that the data is probably not as good as US data, and we need more research to have more accurate prevalence data in each country. We discuss issues related to genetic variants, especially PNPLA3, that can explain some of the variability in prevalence rates. And then we discussed issues related to diagnostics, availability of FibroScan machines, for example. Finally, we discussed issues related to the number of publications and how much research is coming out of South America compared to the academic institutions in the United States, and the need to have more funding available for researchers in this area. I think at the end of the day, we had several presentations with similar outlines. So we discussed Middle East, for example. We talked about Africa and other parts of the world. So that was the first session. Mazen can tell you about the second part of the Health Disparity Summit.
I wanted to say that that session on disparities in different regions of the world and globalizing our knowledge about fatty liver disease and NASH is one of those things that is really spectacular about this meeting and the kinds of initiatives that we're trying to put together. I think that kind of work opens the possibility to do what we need to do, which is to try to tackle this at the global level and utilize everybody's resources and the incredible networks that we have to try to tackle this condition.
I think the next session was to talk about disparity further, and Fasiha Kanwal started talking about nutrition and the role of nutrition in disparity and non-alcoholic fatty liver disease. And food insecurity came as a major concept here, and its variation among different parts of the world and different socio-economic status. I did follow with the non-invasive testing, and my task was to talk about wet biomarker and if there's any variance in around the world disparity. So I started the talk with talking about the different guidance that we have, including EASL, ASLD guidance from South America as well as Asia. And then I went further and talked about if there's any difference in terms of wet biomarkers or serum biomarkers between different ethnicities. The bottom line
fine. We need more research on that. Rohit Lumba followed me talking about imaging biomarker. Same kind of story. There's some variation, but more research is needed. Finally, Stephen Harrison's closed the session, and his discussion was about treatments for non-alcoholic fatty liver disease and if there's any differences. And he's talked about like how certain areas of the world are less included in trials, although they have more prevalence. He's talked about improvement in the Hispanics enrollment in trials, but that we're still not there yet. So it was a really good session with a very good discussion.
Yeah, all right. Anybody want to follow up on Mazen?
I mean, one thing that struck me at the session when Stephen was presenting data from clinical trials, advanced clinical trials, phase 2B, the majority of patients were Caucasian, and we really have almost zero representation of Middle Eastern patients. And when you look at African Americans, other ethnic groups, and not that many patients are being enrolled in these trials. And this will have great implications when we're going to try to generalize the findings from these trials to other populations. So we need to do better.
I think that's right. We covered that not so long ago when we talked about the lack of different ethnicities in clinical trials. I just wondered how much data was gained from South Pacific Islanders and Indigenous Australians, because they have really, really high rates of obesity, type 2 diabetes, food insecurity in the Indigenous Australians is really high, and the more rural you get, the more it becomes an issue because of the cost of food, and by the time the food is available, it's really, really poor quality, so it drives people to poor quality foods and fast food. And we really have a problem in Australia with the Indigenous population, but we also have a lack of data. There's a real lack of data despite screaming HCC rates, and I just wondered how much of that was covered. I know we've discussed the Hispanic populations and some of the others, but whether or not there was any information available on the insecurities there.
I don't recall a presentation on Australia. If there was one, I'm just not recalling it. What I do recall was striking, though, Louise, is exactly the same kind of thing you described. It's apparent in Middle East and North Africa, where you have countries that have rates over 50% for the total population, which is far higher than we see here. And there was some discussion in Asia about two ideas. One is that in certain parts of Asia, kind of South Asia, you get the same kind of thing. And in East Asia, what you get is a lot of lean NAFLD or lean NASH. But I don't recall Australia specifically coming up. Do any of you folks recall?
No, I agree with you, Roger. There was not a session on Australia, but one thing you mentioned, Louise, is food insecurity. And Dr. Fasiha Kanwal spent some time during her presentation discussing this topic. Even in the United States, we have many families that have food insecurity, and they also live in these healthy food deserts where, they just don't have access to healthy foods. And typically, healthy foods don't last on the shelf as long. They tend to be more costly. And then even when you buy them and you have them at home, you can't store them for a long period of time. So these are very important topics. I agree.
Let me comment on Australia. The first and last author of the Asian guidelines that I presented, they are from Australia. So I wonder if it was combined with the Asian region.
I want to say something different, which is I think that there's a geographical difference in between where these minority populations are compared to where the trialists and the research centers are at and the kind of population that they reach. I can predict the future as poorly as anybody else, but if I were to try to do that, then I would say we're going to use the current populations that we tend to do research on to show the safety and efficacy of these medications. And we'll have to wait until post-approval commitments and phase 4 data to have local investigators access their own populations and answer the questions that will give us more data for the less represented racial groups. This is what has always happened in the last 30 years that I have been paying attention, but I think that this is what's going to happen here as well.
Marcelo, we did a Black History Month episode about a month ago, and it was a challenging thing because this disease doesn't have a lot of history. And incidence is relatively low among non-Hispanic American blacks. But Donna Cryer was on, among others, and wound up talking about exactly that and asking whether, in fact, this was a chance. She talked about history as being prospective, and this maybe being the first chance to get that kind of thing right. And Stephen was talking about that a little bit as well on that particular episode. I know because I did an interview with Zobair on this morning to be part of this conversation, that one of the things I think that he would like to see focused on and I think from your comments, Marcelo, you as well, is changing that paradigm, figuring out how to get more folks into the more different ethnicities of the original trials so that they don't have to wait 5 or 10 years being told this works the same way in you, it doesn't everyone else, and then finding out that for certain ethnicities that's not right. What other steps is CLDF taking, or can CLDF take, beyond this discussion, which I thought was great, to try to drive awareness of thought on that kind of thing forward, do you think?
So we're definitely going to move forward this initiative. We're going to try to get together all the different players to design solutions for the future. Clearly, financial support will be key to being able to empower those who are the ones that really reach these populations to be able to include them in research trials. They're not going to come to where they don't get medical care. So we need to bring the research to them rather than have them come to the research centers. It's sort of like a change in the paradigm. First step to any big solution is to define the problem. So I think that we're starting to define the problem. We need to understand the problem, and then we need to propose some next steps and solutions, and we are committed to trying to do that work.
Fantastic. Any more comments on that subject?
Yeah, I was just going to comment in the context that I fully agree with that. When we talk about insecurities, it's actually really important that we take the research to the population. Because if you looking at the Indigenous Australians, and America is not dissimilar in the vast territory that you cover and the distances that people have to travel, in that around about 22% of the population, Indigenous health, actually in the cities and have poor access to quality food. But when you go rural, that's up to 43% of that population. So if we're only addressing populations in city centres and in local facilities, we lose the patients who are actually most affected by food insecurity because they can't get it, you can't travel with it. It's always funny how a fast food outlet can always get the food to those areas way better than anybody else can. The important item there was we need to be more mobile. We need to get the research there. We need to get those patients. They are the highest risk. They are the population that we need to know best and most, and they're actually the population that we know least at the moment in all ethnicities and in all locations.
Something that I want to add is that the first place that we need to try to reach, and the first place where we need to start to make changes is with the pediatric population. So you can argue that this generation of adults is already committed, but we should be trying to prevent this in children so that we, can put a stop to this epidemic.
Question. I've been coached by my friend Ms. Campbell on this over the last 2 years. Is the key to pediatric more about treatment or more about education, or yes?
It's education and it's public policy.
Okay, Mazen, go ahead.
No, I was actually going to call on Naeem on that as well. He's done a lot of research in the pediatric population with many remarkable outputs, so I'd love to hear what he has to say.
I agree with Marcelo that the earlier you start with education and changing policies that are leading to the obesity epidemic in children, the better. But we have to realize that 17 to 18% of children are obese in the United States, and another 17-18% are overweight, and many of them have fatty liver disease. So earlier studies showed the prevalence around 10%. We have more recent data that we shared at one of the liver meetings showing that if you look at adolescents, you're talking about 20% having fatty liver. Of course, they tend to have less advanced fibrosis. Cirrhosis is still rare in the pediatric population, but once you get to these, 16, 17-year-old with F2, F3 fibrosis, the future is bleak really for them. And we do need to also develop drugs for the pediatric population. So I think this is part of phase 3 drug development, at least in the United States. You need to have a pediatric study plan. We are working with several companies that are in phase 3 now to imagine how it's going to look like when we design the pediatric trials. We need more clear guidance from the FDA and EMA on what they would accept as an endpoint for pediatric trials. So this is an ongoing discussion, but I think we need it all. We need the education, the policies, but also we need the same things we do in adults, from diagnostics to therapeutics.
Can I ask, Naeem, how we get across then? Obesity and all of this is driving so quickly. How do we get across the argument of we need data? By the time we get data on the adolescent population now, if you look at Tracy Simon's work, they're going to be dead. Sometimes we've got to take that leap of faith. We've got to go ahead of the curve and prove that it's a benefit. We know education works. Can we wait 15 to 20 years to drive the data argument that we see with obesity? Or do we actually reverse it slightly and say, what's the worst thing that's going to happen? People are going to survive and live longer and healthier. Because we always get the argument from the opposite, data. But in a disease like this, in adolescence that's moving so quickly and with such devastating outcomes, can we really afford to wait on the old paradigm?
No, we should not wait until we have, more data on the natural history, because as you said, we don't want to wait 20 years. We need to extrapolate a little bit from the adult literature with the idea that we will generate that data, we will have a better understanding. But as you said, you have a 16-year-old with stage 3 fibrosis on biopsy, which is not unheard of. Actually, if you look at data from tertiary academic centers when they biopsy children with NAFLD, about 10% will have F3 fibrosis. So in that scenario, I think we need to be more aggressive and extrapolate from the adult data until we have more pediatric specific data. I couldn't agree more. And unfortunately, with the way research is done, this is a common practice in pediatrics that sometimes you just have to go with the data you have in adults, apply to children until you have your own data.
Yeah, so Marcelo, just 1 second, but to expand on one of the names, Miriam Voss was telling me, I don't remember if she's telling me or she said this in presentation, that she has at least 3 patients in her practice who are 14 and 15 who are cirrhotic already. That's less common, but certainly happens. Okay, Marcelo, please go ahead.
I do want to say that there are things that we can do today and things that we cannot do today. So as far as medications, we absolutely need to prove safety and efficacy before we take any sort of leaps, and we have to be rigorous about that. I do not advocate cutting any sort of corners, but we can start at a population level to promote the things that we know that are beneficial for this disease. And I think there was very good conversation throughout the meeting about dietary and lifestyle modification. And part of the problem of why those things don't work is because there's not enough people that are committed to it because of lack of support. So that goes a little bit back to laws, government, and those kinds of efforts outside of pure medication to try to put our efforts where they're going to make a true impact. And if we can get these kids to exercise and eat better, they will get better. That can be done. So there are things that we can do today, not medication. We cannot do medication today for pediatrics, but there are other things that we can do today.
So question. In the UK, one of the important things that they have done, and Louise could talk about this far more than I, is actually start to take on the food industry over the question of labeling. And in fact, the food industry has now come to the table and said, we'd like to label better. We'd like to be clear about this. With the idea that labeling should address these issues, and labeling should address sugars a lot more aggressively than we have otherwise. In New York City, in the States, either because of the nature of who's powerful in lobbying or what folks are concerned about, that's been a much rougher road to hoe. First of all, Louise, did I capture the UK correctly? And then to the other 3 of you, can you see the US getting to a place where we can become part of an effort to lobby for not just telling kids or parents you got to do better, but actually starting to change the nature of what gets advertised?
Roger, I actually want to just step in quickly. There has been an effort actually in the United States, and I don't want to get political, but Michelle Obama many years ago launched the My Plate concept. That I do agree with you that we should do more and press more, and it shouldn't be just changing from administration from Democrat to Republican or Democrat to Democrat. It should continue, but we do a little bit less a better job as entire system in the United States compared to England, for instance.
In the context, Michelle Obama, if we take her as the example, her program came out of the fact that one of her children was seen by a pediatrician and told that they had fatty liver disease, or they were overweight, and the presumption was they may develop fatty liver, because she covers it in her autobiography, which I've read. And it was out of that, because they were all travelling, that they were eating a lot more processed foods and a lot more junk foods, and the children were young. Most people don't have access to pediatricians. Now, these are highly intellectual and intelligent people, and it managed to happen in their family. The majority of people, particularly those of lower socioeconomic classes, don't have access to chefs to be able to work that schedule for them, or the information. So if it happens in higher economic families and well educated, we have a problem. So she started that foundation. It's a fantastic fantastic initiative, irrespective of any political divide. It's good. Here, the Bite Back 2030 campaign is driven by young people in their teens and early 20s to stop industry and particularly social media sending 500 adverts a second for junk food. Now, the government here has done very well in the context that they're considering turning around a U-turn on it, but they're banning advertising of junk food before 9 o'clock. They've already done a sugar tax. We know that South American countries have done that, and it works. So there is a move to help childhood obesity, but there is no education in school on it. There is none of the education of how we operate and look after our bodies to help us be weller for longer in life. That's for me where I'd like to see the education. That's where I'd like to see families and children taught a lot younger. The most complicated system that we're ever going to come across is how we look after ourselves. We don't even know the basics. And I think that's where education needs to start for me, and prevention in that, and more activity in school, but better school meals. So I think it always has to start a lot younger, particularly if we're going to save the generations that are there now and the ones upcoming.
Just to go back to Roger's comment about can we actually be the engine for that change and can we push for it? With fatty liver, this is sometimes for the families, as you said, even with Michelle Obama, this is the first sign that, eating unhealthy food, gaining weight can lead to organ damage. The liver is probably the easiest organ to demonstrate this. When you say your child is overweight, obese, people don't think of obesity as a disease. When you say you have high cholesterol, it doesn't translate to them that there is heart damage. Even with pre-diabetes, they don't understand that the pancreas is sick. I think with fatty liver, once you say that, it's kind of a shock to them. And maybe we can use this, not to use scare tactics or anything, but I think, this is one of the first organs where you see evidence of the damage caused by unhealthy diet and sedentary lifestyle. And maybe it could be a starting point for a campaign where we actually sit down and discuss with the health policy makers and food industry and be more specific to fatty liver as opposed to obesity, which has many issues related to stigma and social issues. I think maybe focusing on fatty liver would be a good starting point.
Yeah, and Roger, let me add one thing also to that. I still think we have a long way to go. There are a lot of foundations that they help medical research, and a lot of them are focused on cancer, which is very, very important topic. But guess what? Obesity leads to cancer, and it's not one of the most common associated factors or cause. Fatty liver is associated with cancer, so I'm gonna call people hopefully to help us. The Gates Foundation, Miss Melinda French Gates and Dr. Priscilla Chen, that they support medical research to support us. Maybe you can send our audio to them and convince them that they need to get the non-alcoholic fatty liver, or along Michelle Obama. We'll bring all of them on the show.
I like it. I have to tell you what, I like Naeem's comment, because if you want to pick one statement that can get people to sit up, it's American diets today are damaging the livers of 1 out of every 5 kids in adolescence. That's a pretty intense number. And sometimes you really have to just cut to the heart of what matters. And I'm a big fan that you should always be optimistic twice and pessimistic once. I think you're right. People don't think that obesity, well, you can lose weight. But until you turn it into, there is something in your body that you are damaging by doing this.
It's getting worse.
Yeah, certainly is. Other comments? I would like to take a few minutes and talk about the Saturday morning sessions. Other comments on health disparity and diet, I think we've covered pretty well.
Yeah, I want to make a quick comment on that day in general for the CLDF. It's great leadership. Thanks to Zobair, Marcelo, Ira, Sammy, and I'm sorry I'm forgetting anyone. Great conference between the NASH Connect and what we're going to talk about next, Liver Connect. It has been really landmark conference, and I really enjoyed it. Enjoyed the weather, enjoyed seeing friends, and we're gonna talk about Liver Connect, but you cannot talk about a better start than having the Harvey Alter starting that day. So let's dig into Saturday.
Let me second that. I think actually you guys have done a great job of putting together a conference that brings people together and gives them space to think and process. And one of the comments I made to Zobair in the interview this morning was I was really interested with how you guys set up the NASH session on Saturday, right? A couple of short presentations, but mostly questions and common reflection on major issues. How did you feel that worked? Did you get out of what you were looking for? And panelists, how did you feel it worked?
Let me take the first stab at that. I think that the feedback that we got was 100% 100% in favor of that format. Most of the people that came to the meeting knew what we were talking about, and rather than being put to sleep by a long lecture, they were stimulated by the conversations and back and forth and counterpoint of those experts that were involved in the different sessions. And I think it happened in pretty much every session, from NASH to pediatrics, from pediatrics to cirrhosis, to the complications of cirrhosis and to viral hepatitis. It happened everywhere. And so we always get a lot of feedback and try to get a lot of feedback after each meeting and try to make it better for the following meeting. We did a good thing this time. Everything really went well. And to my knowledge, and from the personal feedback that I got from a few dozen people, was that they loved this format. It worked.
I will echo that as well. I didn't get the feedback. I totally loved it. And you cannot go wrong when the maestro is Zobair Younossi. And then you have in the panel, of course, there are many other experts, but we had an amazing experts. I want to give a shout out to our women leaders, Alina Allen and Manal Abdelmalek. We had the father of fibrosis, Scott Friedman. So that was really, really good. As you know, I was a speaker on this panel, so I think it was a bit challenging to talk about NITs or treatment. Stephen also was challenged about all that, although we know it well, in 10 minutes, but we did manage. So maybe in the future, I will say, give a few more minutes to the talk. I mean, I'll give you an example. Someone said, well, you did not throw any jokes during your talk. And I said, there was no time for that. I had 42 slides and I gave in 12 minutes. So I had to go boom, 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 done. But it was absolutely amazing. I enjoyed every second of it, despite the boom, 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 done.
I totally agree. And one of the things I loved was even the conversations, right? Could go from the theoretical to the real and back again at warp speed. There was one moment, I don't remember exactly the topic, where Scott Friedman was talking about the theoretical. Naeem came in and he talked about, how do you treat patients? I do this, I do that, I do this, I don't do that. And then it jumped right back to the theoretical again. And I thought the interplay of the two was really, really helpful. Whoever was listening, whatever they wanted to get out of it, they could get out of it. And if they wanted to put all the pieces together, that was there as well. And yeah, hats off to you. I can't imagine a better panel. I agree. I mean, a better set of people and then a better dialogue.
If I recall correctly, you were referring to Scott talking about more rare pediatric diseases, and Naeem basically in about 1 minute explained two conditions and how to work them up.
Yep, that's exactly right. Thank you. Naeem, you did not present at the session, but you certainly were engaged in the dialogue. How'd you feel about that?
I really enjoyed the session. I think we provided high-level updates on diagnostics and therapeutics, and kudos to the presenters, but they were able to really discuss most of the data that's out there. As Mazen said, in 12 minutes, I mean, how can you discuss every diagnostic test and every drug in the pipeline? But they really did a nice job summarizing. I'm excited also that potentially next year we can go from the theoretical to the practical and actually talk about, okay, well, these are the non-invasive tests that we are using today to decide who's going to go on the first FDA-approved medication for NASH. This is how we're going to monitor. And then we're going to talk about, the first medicine or maybe two medicines next year that will be FDA approved, and then tell people how we're going to choose which one to use first, how we're going to monitor response to treatment, what are the side effects that they need to be looking for. So I'm hoping that this is the last year that we are in the theoretical realm, and next year we're going to be very practical. And it's going to be very exciting for the attendees because these are things they can do now. They're not in the context of clinical trials. They're not in the context of a new biomarker trying to get to FDA approval. It's going to be real life, and we will have options.
Naeem, I couldn't agree more, except I suspect it might be 2 years, not 1 year, but we'll see.
Well, I'm the ultimate optimist. I've been saying.
Yeah, on this one, you really are the ultimate optimist because I know when the readouts are and there is meter-arm data, and I can't imagine FDA will get through it quite that quickly. But no matter how good the readouts are,
And he's always right. That's why we didn't have a follow-up comment.
Well, that's why I followed up, because then I get to be wrong. It's a wonderful thing. But I pay myself to be wrong. Not a lot, but I pay myself to be wrong, so it's okay.
Then let's send to Naeem Al-Khoury.
Okay. So Naeem just led to the lesson I'm thinking, which is, first of all, I think that this and NASH are very, very different conferences, but having them both, and not only one's in the cold and one's in the hot, but in what they're formulated to do. But I think they really neatly bookend going from different ways to think about where we are and where we're headed and how to tackle the real challenges. And each, I think, is helped by the presence of the other. What do you foresee? Naeem already told us. Everyone else, what would you foresee for Liver Connect and NASH Connect next year? How would you see it being different How do you build on this experience?
Again, I don't want to predict because I have no idea what's going to happen, and I cannot talk for others. I think that both meetings have their work cut out for them. We definitely have enough challenges in the research arena and in the study formulation and interaction with FDA arena that I think that we could do the NASH meeting every other month. There's plenty of work to be done. As far as the Liver Connect portion of NAFLD and NASH, clearly we are just getting our tools ready to be able to roll this out to the community, to those who need to participate, to the primary care physicians, to endocrinology offices, gastroenterology offices outside of academic centers. We need to involve all the community, utilize the development of telehealth medicine, definitely empower APPs, and we need to work on all of these aspects in order to be able to make a dent in this condition. So I think that we have plenty of work to do in the years to come.
For me, for next year, I want to borrow from other episodes. With Litmus and Nimble and NIT coming, there's a true motion driven by patients and patients' advocacy to find a solution for the screen failure, patient not being enrolled in trials because of them. So I think we're not going to see the replacement of liver biopsy in phase 3 next year, but the movement will magnify and we will see more and more data, and hopefully the FDA and EMA will be more engaged. And that will be also important as we get closer to the hopefully approval of resmetirom, because we're not biopsying in clinical care all these patients. So next year, I think you will hear a lot of people like, what do I do now? I mean, one of the things that when I was presenting at the NIT and Scott Friedman asked after the talk is like, so what do we do? And sure, I can tell him what do I do, but I cannot make any recommendation as of today because there's no formal recommendation on which NIT to use, especially to monitor treatment. We'll start shaping that next year or so with more data, more consortiums, and a drug getting closer to be approved.
I totally agree with Mazen there. We do have to move to an NIT. It'd be interesting to see what the license granted on. If it's the normal sort of way, it'll be granted on a biopsy proven, because that's where it's come from trials, and obviously we want to move beyond the biopsy. But I was mentioning to Roger earlier before we were online, I did a whole series of patients this weekend, and if that's the style of patient coming through, I could have recruited to a NASH trial on all of the new patients coming through. High fibrosis, most caps well above the 300, let alone the 200s, and this was a general list that has been waiting 12 months. COVID has not been kind. Most of it was NAFLD or MAFLD, and most of it would tick screening. I didn't have any blood tests, so I couldn't do fast score or anything like that, but these are regional units, and we could just recruit, but hopefully some of these patients will get access to help recruit these studies, and that's where we're going to have to be finding the treatment from. So Litmus, Nimble, NIT, all of the data that we're getting now with being able to track with non-invasive therapies, we need to put it into practice and really put it into the clinical realm and discuss it with the agencies for that.
You know, I think we had a nice session on NASH on Saturday that started with epidemiology, and I felt like in the NASH Connect we covered epidemiology very well this year. So I would suggest next year, we use the second talk from Saturday morning, which is the NITs, and maybe do NASH Connect on NITs, because I think we have so much data that's being generated, but we need to all sit down and have a discussion how to utilize them. There's a lot of focus on this new AGA screening algorithm that starts with FIB4, and then, you take certain patients to transient elastography. But I want to emphasize that this is for primary care physicians. This is not what hepatologists and gastroenterologists will be utilizing to decide on treatment decisions and how to monitor patients. So we need to have more consensus, realize that these NITs are complementary, figure out a way to combine them that is cost effective, that will not break the system. So a lot to talk about, whether we're talking about what biomarkers or imaging tests or combination like the FAST or the MAST. So that could be potentially a good topic for next year. And then, of course, maybe in a couple of years, as you said, Roger, when we have drugs, then maybe do another NASH Connect on the new drugs and how we're going to utilize them. And I agree with Marcelo. We need to include the advanced practice practitioners, APPs, because at the end of the day, we generate the data, we invent the algorithms, but they actually apply it to their patients and take excellent care of them. So we need them to be very involved early on.
Let me agree with Naeem 100% and get a little bit controversial. I might upset a couple of friends or more out there, but also we're talking about AGA as well as EASL algorithm in the primary care setting, starting with the FIB4 followed by transient elastography. And here I am in trouble. I don't think this is set with stone, especially with the FIB4. It's a great test, it's cheap, it has high negative predictive value, and we want the PCPs to do something. And if I get them to do this, I'm very happy. But I want to remind people also that there are studies that showed half of the people in the indeterminate and the low cutoff zone had clinical outcomes. So if I want to predict in the future, once primary care, they have a pickup on the FIB4, I think the door is open to replace it with a better test that give us more confidence. And I know many others disagree with that, but our disagreements bring us into research and improving patient care.
The last 2 points serve to demonstrate actually why they're doing clinical care pathways in the first place, right? Which is the expectation isn't that the screening of the patient will start with a gastro or a hepatologist and that person will be doing FIB4. The idea is that if we fantasize a world where we could educate all the type 2 diabetics out there who have never been evaluated by their doctors that they need to get evaluated, and fantasize that they then go rushing into their endocrinologist offices, or maybe they just jump straight to a hepatologist, we don't have enough doctors to handle the demand. So the reason for the whole clinical care pathway challenge is so that if we amp up awareness rapidly, that we can get people evaluated at a place where it's efficient, where they don't have to wait a year, as Louise pointed out, and then by the time they get scanned, they've all got CAPS over 300 because they waited a year. So I think it's important not to overstate the role of FIB4, but not to understate it at the same time, which is Naeem, when Ian Rowe comes on and talks about leads, he talks about it being a very cheap test that can put people through quickly, and they're not going to miss that many people. And then they can go to a second test where they can start screening out the people that might have gotten screened out by a more sensitive test the first time.
Roger, I agree that FIB4 is, cheap and readily available. My worry is people don't realize its limitations. Mazen mentioned a couple of things. It doesn't work if you're younger than 40 years of age. We actually have data that in young adults, FIB4, the performance is not acceptable. Actually, when you take patients with advanced fibrosis, no advanced fibrosis on biopsy, and you run the FIB4 in younger adults, it just does not discriminate for you. It definitely doesn't work in children. And then you have to increase the cut point to 2 instead of 1.3 in elderly. Otherwise, every elderly patient who's like 75 will end up with high FIB4 just because age is part of the score. In reality, it only works if you're between 40 to 65. You want to use the cutoffs, and there's a lot of nuances. I mean, if you have a viral illness and your platelet goes down because of the virus and you happen to calculate a FIB4, it's going to take you on the wrong path. I'd like to have something that's more liver specific eventually. I agree with you. Where we're at today is really not a good place, and we need to screen more people and have something cheap. So I think it's a step forward, but we need to also educate more and more about its limitations and when it's not a good test to go by.
Marcelo, go ahead.
Yeah, I wanted to say that I'm not necessarily going to speak in favor or against the FIB4. We definitely need a test that is simple to use for triaging at the primary care physician's level. So if we know that we have millions and millions and millions of people at risk, clearly there's not enough specialists to screen them all and evaluate them all and decide who requires therapy or not. The entry into the system has to be at the primary care physician's level. It has to be a simple single test that will triage and do the best possible job for the majority of patients. And then once the triage is done, those at high risk move on to specialty care, and those not at high risk move on to down the pathway. It's not that they don't get looked at anymore. They just go down a different pathway that does not involve immediate specialty care. But we need a simple test. Today, it may be the FIB4. Tomorrow, we may have a better test, but we need a test.
But it's interesting when you talk about that. If you look at FibroScan, if you look at the majority of the people that I scan in the lifestyle clinic, they have soft, fatty livers. They need endocrinologists or cardiologists. They don't need hepatologists. So it screens them out. There was a vast amount of people that I've done recently in healthcare that again, they all had cardiac or diabetic, but had soft fatty livers. We were screening them out of hepatology. They didn't need to come to hepatology. They needed to stay where they were in endocrinology and cardiology. So we have tests, but we need to be more accurate. I totally agree with you. But are we ever going to get the ideal blood test on an organ that regenerates itself with so much new tissue? I'm not 100% convinced that's actually ever going to occur. It's not the nature of the beast, I suppose.
You know what I would like to see, Louise, is you know how we screen with a lipid panel or heart disease, and we do it on everyone, right? I mean, it's part of the guidelines now that all adults in the United States need to have a lipid panel at a certain age. Actually, it's even recommended in children. With all the limitations we have with AST, ALT, I would love to actually get to a point where we get to do something similar to transient elastography, just at some point in life on everyone, similar to what was done in the enhanced database, where they actually did transient elastography on about 10,000 individuals. The problem has been the cost of these machines. This is what we need to think about. Can we get to a point where it could be a handheld device that doesn't cost much, where you can do a quick liver screening, and all it's good for is for the negative predictive value to tell you that, as you said, you have a fatty liver that's soft, come back in a couple of years, we can do this. I think that is feasible. I just bought my own ultrasound machine so I can go around Phoenix, do my own liver biopsies, and it didn't cost me much, honestly, to buy an ultrasound probe that will show you beautiful pictures of the liver. So once we get to that point, and I think the other thing that's going to probably happen is having these NASH clinics that will become part of, you know, how we take care of patients in the United States, where you just come get a quick screening. In fact, in our offices in Arizona, we offer a FibroScan for anyone who's interested, and we do about 1,000 FibroScans each month. And as you said, 80% will have low liver stiffness, and we can reassure. So only 20% will end up coming. I know we have a lot of work. I know we're not there, and I'm not saying we should proceed with this algorithm, but this is where I would like to be in the future, where it's point of care ultrasound that can measure liver stiffness, and this is how you get more accurate results than AST, ALT, or FIB4.
Whether the test is going to be called a FIB21 or a VCTE82 or whatever the system is, it needs to start at the population level, and then it needs to trickle down to specialists. I spent hours on end on these networks of people that game online and talk to people all across the world, and it is a lot of fun, and it complements my serious side. Hopefully that was quirky enough for you.
That's a winner. I mean, you know, I've got a 32-year-old daughter who's been a gamer forever and will be a gamer for the rest of her life, and they're just a different breed. Well, I think it's time for us to jump, but let me thank each of you for joining us today. And Marcelo, Mazen, Louise, Naeem is gone. Thank you so much. I will be back with Business Report in a couple of minutes.
And now for the Season 3, Episode 15 Business Report.
This week, I'd like to start our business section by shouting out in support of our Ukrainian friends and colleagues. This is a statement I've heard expressed repeatedly in both English and Ukrainian. Please forgive my Ukrainian. Slava Ukraini, Heroyam Slava. Glory to Ukraine, glory to heroes. We've had a small change in the upcoming schedule, but it shouldn't make things less exciting. The schedule from here through mid-April remains strong, and I anticipate announcing the rest of April and most of May next week. Next week, Chris Estes returns to drive a discussion on what disease modeling can teach us about drug development strategy. Stephen will be back on vacation to join us, and Jorn Schattenberg and Alina Allen will be with us as well.
There's been a change for March 28th.
Unfortunately, Jonathan Epstein developed a conflict the week of March 28th, but any episode that includes Scott Friedman, Stephen, and Neil Henderson from the University of Edinburgh is guaranteed to be intellectually challenging and a fair amount of fun. A lot of humor in this cast. The first week in April, we'll preview the Innovations in NAFLD Care 2022 workshop taking place in Barcelona the first week in May. We'll have co-chairs Jeff Lazarus and Jorn Schattenberg with us, and 2 more participants in that meeting. The week after that, Naeem Al-Khoury and Jorn Schattenberg will join us to share thoughts about what the NAIL NIT retrospective analysis might be able to tell us. Naeem was telling me in Scottsdale this weekend how excited he is about that episode. The rest of the second quarter will include the Innovations Conference itself, the 5th Global NASH Conference, International NASH Day, live in London, EASL. Previews and events will take up much of May and some of June, and details on all that will follow next week.
The buzz is back big time, and the vault is loaded.
This past week is already the 5th biggest download week in the history of this podcast and may get to 4th or 3rd by the time our scheduled week ends on Tuesday night. Listeners return to the vault for some really interesting pieces. For the second week in a row, the most downloaded episode from 2020 and the first 9 months of 2021 was our 12th episode, which focused on FDA's complete response letter to Intercept Pharmaceuticals over OCA. This week, Season 2, Episode 49 on clinical care pathways drew a lot of attention, as did its conversations. 2 episodes a little earlier in Season 3. Episode 9 on nursing and Episode 11 on the NIT introduction also did extremely well. So with that, I want to thank our team, Magic Mike, Eric, Steve, Murph the Magnificent, for a fabulous week scrambling to keep up with the challenges posed by the CLDF scheduling. Magic Mike actually joined me in Scottsdale to record a future extra show that Madrigal is sponsoring. More on that in a week or two. In signing off, I want to repeat the same phrase I used last week, Sabudo Ukraina, which translates loosely into all will be for Ukraine. I'll have a new phrase next week. The eyes and hearts of the world belong to our friends in Ukraine. Stay strong. And with that, I'm off. Stay safe. Surf on. I look forward to seeing you again next week on the podcast. Bye-bye now.
Today's episode of Surfing the NASH Tsunami has been sponsored by Madrigal Pharmaceuticals, a clinical-stage biopharmaceutical company pursuing novel therapeutics for NASH. Madrigal's lead candidate, resmetirom, is a once-daily, oral, thyroid hormone receptor beta selective agonist that is designed to target key underlying causes of NASH in the liver. Resmetirom is currently being evaluated in 2 phase 3 clinical studies, Maestro-NASH and Maestro-NAFLD-1, designed to demonstrate multiple benefits in patients with NASH. For more information, visit www.madrigalpharma.com.
You've been listening to the Surfing the NASH Tsunami podcast. Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website. Thanks for listening. See you next week on the podcast.